Well, welcome back, everybody, and it's good to see everybody. Our next speaker is Dr. Michael Mannstadt from Boston, Mass. and Harvard Medical School. He's going to be speaking on the conventional treatment of hypoparathyroidism, and we welcome Dr. Mannstadt.
Great. Well, thank you very much, Bob, and thank you and the committee for inviting me to give a talk. I'm always happy to be here at the Hypopara Association meeting. I especially like the interaction with you and everybody. Obviously, it's limited in the Zoom world. On the other hand, it's so much easier to actually participate. I'm not even in the States right now as I speak. So let me share my screen and get my slides up and running. I hope everybody can see them. So this is the topic of my talk. It's conventional treatment of hypoparathyroidism. These are my disclosures. As you know, I'm working closely with several companies involved in hypoparathyroidism and enjoy it. And so first, what is conventional therapy, as this refers to my talk here, and that is oral calcium and oral active vitamin D, for instance, calcitriol. And this is as opposed to treatment with PTH or PTH-like molecules. And I'm happy to hear that you have heard a lot of excellent talks already about the PTH and PTH-like molecules and other new treatment options for hypoparathyroidism. And the replacement of the missing hormone PTH is very logical, right? Everybody understands that, and scientifically it makes a lot of sense. But then why are we talking about conventional therapy? Well, there are several reasons. The main reason here is most patients with hypoparathyroidism are on conventional therapy. So we need to know how to optimize it and we need to know about it. Certainly when there are patients just new to the disease hypoparathyroidism, typically they're anyway put on conventional therapy. And so I will talk about this. Probably a lot is known to you already because you live it, but I will try to give some background so that everybody's on the same page. And you also know that I've in the past talked about PTH replacement, so I'm very interested in PTH replacement and think that this is a superior therapy, but we do need to know about conventional therapy. And in addition, the recent international guidelines that are being published, and some have been published already, do recommend conventional therapy as first-line therapy. However, there's a lot to say about this. So these are weak recommendations and based on low quality evidence. In other words, we really don't have any strong evidence one way or another. So don't take this as, oh, people recommend not to take PTH. And then the comment in the guidelines is that when conventional therapy is deemed unsatisfactory, the panel that made these recommendations considers the use of PTH. All right. So I cannot talk about treatment for hypoparathyroidism without giving a little bit of background on PTH, despite the fact that I'm talking about conventional therapy mainly today. And so we also understand in general in biology, and this is also true for PTH, its biological importance on the evolution, how it's being made and how conserved it is. And so when water animals, fish, when they take care of their calcium metabolism, they have an easy life because they're exposed to high calcium all the time in the ocean and in the seawater. And so they didn't need special glands to take care of the calcium homeostasis. But then when animals moved to land, amphibians, they needed to develop a mechanism to ensure adequate levels of calcium, despite the fact that they were no longer living in the ocean. And so that's where the parathyroid glands came in. PTH itself already exists in fish, but the glands actually were developed later. So this was hundreds of millions years ago, right? And so you see that there's a strong evolutionary pressure to conserve and to have PTH. It's the important regulator of blood calcium in all land-dwelling animals, vertebrates, also called animals with backbones. And so you see here on the right side, PTH, it's a peptide hormone of a full length of 84 amino acids. What we know about the bioactivity is actually inside the first 34 amino acids, and that is produced as PTH 1 to 34 or teriparatide or Forteo, used mainly for osteoporosis patients. And the full-length PTH is the only treatment that is approved for hypoparathyroidism, Natpara or Natpar in Europe. And you all know about the fact that at one point in the future, the production of this will stop, so end of 24 or after. And PTH action have been reviewed by previous speakers already. So I want to remind you that PTH does a lot of things. So its main action, and we talk mostly about it, is increasing serum calcium. I'm not even sure if you see my point of it here on the left side. And it does it through 3 different mechanisms: on the bone, on the kidneys, and indirectly on the gut. So it increases the calcium by increasing bone turnover and releasing calcium and phosphate, by the way, into the circulation. It reclaims urinary calcium. So it tells the kidneys to not lose calcium, but to conserve it, to keep it inside the system. And it makes the kidneys produce calcitriol, and we talk more about it. This is the active or activated vitamin D, which then in turn leads to a very effective absorption of calcium through the gut. In addition, PTH decreases phosphate, so it gets rid of phosphate in the urine. And so while we are trying to replace the function of increasing calcium, we are really not doing anything with conventional therapy to increase bone turnover or to keep it healthy, so to speak. We're doing nothing to reclaim urinary calcium, and we're doing nothing with the phosphate, right? And so these systems that are nicely working together with the actions of PTH don't work that way here on the right side when there is no PTH anymore. And what we are doing here is depicted on this slide. We're giving oral calcium and calcitriol, which makes a lot of sense because oral calcium will increase calcium, and calcitriol will make it easier for the gut to absorb calcium. And it's actually a very active and potent drug. And so it increases serum calcium, which is nice. That's what we want, right? But it does nothing to the bones, and it does nothing to, it doesn't tell the kidneys to conserve the calcium. And so the more you pump into the system, the more comes out in the urine. And while nobody can feel whether the urinary calcium is high or low, fortunately, there is a potential downside adverse effect, and that's calcifications of the kidneys. Oops. And so this here really is the central challenge that we face with conventional therapy in hypoparathyroidism. And those of you who've had the disease for a longer time, you know very well what I'm talking about. So even when the serum calcium is kept at a quote unquote normal level, meaning that's what the laboratory tells you is normal, and that's what is normal for most of the population, the calcium actually turns out to be too high for those without PTH because it results in hypercalciuria, which is another word for high urinary calcium, nephrocalcinosis, which means kidney calcifications, kidney stones, nephrolithiasis, and that can lead to chronic kidney disease. So therefore, we have to go lower with the serum calcium, right? So patients with hypoparathyroidism on conventional therapy should avoid normal calcium levels. Rather, we should aim for a low to low normal serum calcium. But then the problem is, if it's too low, there are symptoms. And you know about the symptoms: paresthesia, muscle cramps, tetany, tingling, while sometimes they can be mild and okay, other times it's just you cannot go on with your normal life. And so you have to increase the calcium. But when you increase it, then your risk gets higher to develop these complications. And by the way, these complications, first of all, not everybody gets them, and we'll talk about this in a second. And then also they take time to develop. So that's the good news. But this balance is just tough, right? And that's a problem in conventional therapy. For some patients, it works very well, but for others, it doesn't. And it's a constant struggle. Physician tells you, no, your calcium is too high, you have to go lower, but you have symptoms. So what do you do? And by the way, it actually spills over also into the trials with PTH and PTH-like analogs that you've heard a lot already, that often the investigators actually want the calcium to be low or normal because that's what we are used to. But I believe that for good PTH replacement therapy, we should be able to actually aim for a normal serum calcium, because then good PTH molecules works for a long time, over 24 hours, and will actually not result in high urinary calcium, and the calcium level is normal. All right, but we are straying here from our topic. So let's go to the next one. So what about chronic kidney disease? Is that a real problem or not? You will hear a talk from Michelle Rubin tomorrow, I believe, about long-term effects. You will hear more about it, but just as a little preview here. Oops. So this is a nice review that came out last year about the percentages of patients with hypoparathyroidism who have chronic kidney disease. And so here you see the study and the first author, I believe, and the year when it was published, and importantly, the number of patients in the studies, right? So you can imagine that a study that has 688 patients, well, you would really know about this study before you look at the study that has many fewer patients. And here is the percentage of patients with chronic kidney disease. And it goes from 41% down to 5%. And this looks scary, doesn't it? But there are a few things you want to know, and I'll just touch on them. And I agree with you that it's sometimes hard to read medical literature, right? If you're not totally into that as a professional, just seeing the numbers, you can freak out. But here is what you need to know. You need to know that older people, or those with the following diseases: high blood pressure, obesity, diabetes, and others, also develop chronic kidney disease. So in other words, the percentage itself does not tell us everything, because you want to compare, ideally, these numbers with matched controls. What's your matched control? Well, it's another person, roughly the same age, same gender, who has the same percentage of high blood pressure, obesity, and diabetes that some of these patients have. But without hypoparathyroidism, that the only difference really between them is hypoparathyroidism or not, right? That's kind of the ideal situation. It's not easy to do. And certainly for a disease that's not very common, like hypoparathyroidism, it's difficult. But I will give you as an example these two studies here. This is the one that actually we did in Boston, and the Danish national study, because they have mentioned this comparison. And so this is these 120 patients from Boston with hypoparathyroidism. And here we compared them with controls. We could only use so-called historic controls. And so I'll walk you through this. So first of all, here you see the percentage of patients with chronic kidney disease. And there's certain definitions that can also change between papers. And here you see age groups. And in black are the control patients. This is a US population, a famous study, an NHANES study, that looks at what's the percentage of patients with chronic kidney disease. And you see it's very rare in young people. And in people older than 69, it's up to 40%. And these are not patients with hypoparathyroidism, right? So if you just hear, well, this group of patients or this group of people have 40% CKD, well, it sounds high. But really, you need to know a few other things. And so now you look at the great bars here. These are these 120 patients with hypoparathyroidism at Mass General and Brigham. And you see here, despite the fact that there is a high percentage already at base, without hypoparathyroidism, it's way higher in patients with hypoparathyroidism. Remember, this was the study, if I just go back, that had the highest percentage here, right? So now let's go to the next study. This is the large Danish nationwide study with 688 patients and more than 2,000 controls. And so you see here, first of all, a hazard ratio. That means kind of more or less the risk compared to controls, which is about 4-fold higher for kidney stones and other things. But the paper nicely actually showed the actual percentages. And so kidney stones, 1.9% of the cases, meaning hypopara patients, develop kidney stones, compared to 0.4% of the controls. Renal insufficiency, 5.1% versus 1%, and seizures, 3.8 versus 1%. Here you see why they say 4 times higher. Well, it's about 4 times higher here, right? And here you see the percentage. So I don't want to minimize the risk for developing kidney or renal insufficiency, for instance, meaning kidneys don't work as well as they should. But it's 5% compared to 1% in the controls, right? So 4% more. So it's not like everybody gets it, right? So that's just one thing that I wanted to make sure to show. And obviously we have a Q&A period afterwards. So if you have questions about this, please send them. I don't see them now, but Michelle will tell me about them, I think. So let's talk about a case and discuss how to improve or optimize conventional therapy. So we have a 50-year-old otherwise healthy woman who has post-surgical hypoparathyroidism for more than 10 years. And here's how she came to us. She's on citracal, 315 milligrams, which is calcium citrate. She takes 6 tablets twice a day. She's on calcitriol 0.25 micrograms. She takes 1 a day. And these are her labs: calcium, phosphorus, and 24-hour urine calcium. Here are the range of her numbers that we have. And this is the normal range. And just because I say QD and BID, it's once daily, twice daily, and this is 3 times daily. So please have a look at the numbers and what she's on, and tell me what you think about what's wrong with this. What would you think is not good here? And we'll have a poll in a second, and Michelle will prepare that. And what you see on the poll, and by the way, if you have a full screen mode, you will have to go to the minimized screen mode. And if you kind of wiggle with your pointer, and then you see on the right lower side, this minimizing button, you have to press that. So you see on your right side, the polling, right? And so you can choose, you can only choose one. So 1, urinary calcium is too high. 2, she's on too much supplemental calcium. 3, she's on too much calcitriol. 4, all of the above. Or 5, only 1 and 2. So please get to your poll and choose what you think is wrong with her or her treatment.
Okay, Dr. Mannstadt, it looks like we do have results. So if you want to let me share real quick.
You are so fast in the audience. So I'll stop sharing my screen and Michelle will show us the results.
Okay, can you see them?
I can certainly see it, and I hope everybody can. So, well, first of all, thank you for those who filled out the poll. So it's interesting. So, there's still people.
Oh, see, that's nice to know.
Wow.
It adjusts as they're answering.
That's excellent. And so, please go ahead. You still have a few seconds. It's very nice. This is better than any political election here.
It's in real time. That's good to know. I did not know that.
Very nice. Now, of course, when you see the results, you might be a little swayed and choose what everybody else chooses. So, but don't be afraid. Just choose what you want to. Great. Good. You know what? Let's stop here and talk about this. So urinary calcium is too high. Absolutely. I totally agree. That's the main problem. And that is a huge problem, right? Secondly, too much supplemental calcium. That's interesting because she was on 350 milligrams, 6 tablets twice a day. I mean, I don't know what you think. I could not survive a day actually with these numbers of tablets, right? Just for the calcium. And so this is way too much. And so you're absolutely right saying it's too much calcium. And certainly those who say 1 and 2 have incorporated that. Too much calcitriol, well, look, she's only on 0.25 and everybody agrees. And all of the above, well, because there's not too much calcitriol, she's just on 1. The right answer would be E, 1 and 2. So well done. So Michelle, if you can stop sharing your screen, I will go back, excellent, to mine. So if you wonder what we did last weekend, we practiced this the whole time. So excellent. So we got this, right? Urinary calcium way too high and way too much calcium. And so what would you do? And that's the next poll, which Michelle will now open up. And that is, do you want to increase the amount of calcium tablets? Do you want to increase the amount of calcitriol? Do you want to add magnesium? Or do you want to decrease calcium and give it 3 times a day? So please choose your answer. Michelle, we will not start sharing yet because I want people to have some time to choose the answer without being influenced by seeing what others would.
This sounds good, Dr. Mannstadt.
Excellent. So what would you do? Increase calcium, increase calcitriol, add magnesium, or decrease calcium and give it 3 times instead of twice a day? Michelle, I believe the answers are flowing in.
Yes, they are.
Excellent. Good. So I would say we'll stop sharing, and if you can share the answers, then excellent. Very nice. So you're absolutely right. So I have to come up with more difficult questions. Decrease calcium and give it 3 times a day. That's exactly right. So if you stop sharing, then I'll go back. Michelle and I are used to sharing. And so this is easy to do. Oops, yes. So obviously we discussed that the calcium tablets are already too much, so we don't want to increase. Increasing the amount of calcitriol, sure, if you also want to decrease the calcium, right? So if you want to do 2 and 4 together, that would be great, but that was not an option. Add magnesium, well, we don't really talk about the magnesium. We don't know what the magnesium is here. And so it will probably not play a major role in the fact that her urinary calcium is high, right? And so you did the right thing and saying, instead of these humongous amount of calcium tablets, we want to decrease this and actually give it 3 times a day instead of twice a day. Why is that? Because you can imagine if you get calcium twice a day, you have a large increase in calcium during a few hours when calcium works, but then you have nothing in between. And so you want to give calcium at least 3 times a day to kind of have a curve that looks better. And so here's what we did. We did decrease her calcium to 1,500 from 3,780 milligrams, right? That's less than half. That's pretty dramatic. And we gave it 3 times a day. But her calcium went too low and she had too many symptoms. So we increased the calcitriol from 0.25 to 0.5. But we did do a few other things. And this case really here is to illustrate some of the things you can do to optimize your care with conventional therapy. So in addition to just reducing the calcium and giving it 3 times a day, we switched her actually from calcium citrate to calcium carbonate. We'll talk about this a little more, but calcium carbonate has a few advantages. First of all, I think for most tablets, it's a little cheaper. And then it comes with more calcium per pill or per salt quantity. So it contains, so calcium carbonate contains about 40% elemental calcium, while calcium citrate contains only about 21%. So that is one of the reasons actually why the tablets have already less calcium, because otherwise they would be too big, although there are bigger ones. And so that makes it easier to give more calcium per pill, so to speak, with calcium carbonate. And so that's what we did, right? So we switched to calcium carbonate. Calcitriol comes in 0.25 and 0.5 microgram strength. And if you are bothered by the number of pills or capsules, then in some cases, you can actually switch to the higher strength, which we did in her. Instead of taking 2 of the 0.25, she takes 1.5, right? And so you see here, these are now 4 tablets. And here they were 12, 13 tablets. So we went from 13 tablets to 4 tablets. We have a better calcium control. And that is also seen here in the calcium level. You see that there are less swings, right? And it's a little lower overall, which we like as physicians because we like to lower the urinary calcium. And we don't have these 9.9, which are too high, right? The highest here is 8.7. And the 24-hour urine calcium went down, right? It's not normal. So what is normal? Well, in women, we want to have a urinary calcium excretion of less than 250 milligrams, in men less than 300. And of course, we want to get closer to that. And so we're coming a little closer there, right? So this is the summary, what we did. And what is the problem now? Well, the problem is the urinary calcium is still a little high, right? So that's the next and I believe last poll question here, and you did really well. That is, what would you do now? And Michelle, if you can pull up the next poll, and the audience, if you can choose one of the following answers: decrease the calcitriol, add a thiazide. Thiazide pills are hydrochlorothiazide and similar. Increase the calcium, amount of calcium tablets, give a phosphate binder, or all of the above. Okay. So please, thank you. Please choose.
They are sharing results right now, so you just let me know when you're ready.
Excellent, good. So thank you everybody for participating in the poll. And as you've seen before, there's no punishment for any answer, so please do tell us what you think.
You ready for me to share?
Yep, so let me stop sharing, and Michelle is sharing her screen. Oh, wow, flawless. Excellent. Well, again, very impressive. So decreasing calcitriol does make some sense in that you will lower the blood calcium, right? And that will lower the urinary calcium. But you remember that when she was on 0.25 calcitriol, when we switched to the lower calcium amount, she had too many symptoms. So unfortunately, we can't do that, right? That's why one would not be correct. Add a thiazide pill, absolutely. That's one of the ways to try to lower the urinary calcium, and we'll talk about this. Increase the calcium. That would not lower the urinary calcium. On the contrary, would increase it. Give a phosphate binder. That's an interesting proposition here. So what are phosphate binders? These are tablets that bind phosphate. They are given in patients with chronic kidney disease. They come in several ways, with calcium or without calcium. And they are rarely used in hypopara patients, except that the calcium you're taking is also a phosphate binder. And that is one of the reasons why you take it with meals, because then you bind the phosphate, right? So extra phosphate binders are very rarely needed. There are some occasional patients who, with all we do, doesn't help to lower the phosphate, and then we'll give phosphate binders or PTH. And all of the above would not be the right answer because of some of the issues that we discuss. So Michelle, you can stop sharing your screen. Thank you for doing that. That really worked very well. And I will go back to my slides that you see. Yeah. And so thiazides, that's really well done. And that's what we did. We added hydrochlorothiazide. And what it did was actually it decreased urinary calcium again, right? So really nice. We went from very high level to not so high levels. The serum calcium is overall a little lower, but in a good range that we like. And given the calcium with meals 3 times a day, lowered her phosphate a little bit, not much. And certainly the pill burden went down dramatically, right? And so this is what is a typical example for optimizing care with standard therapy. And so if you look at your own therapy, think about, is there something that you can actually discuss with your physician? All right, and so because the high urinary calcium, in my view, is one of the several big problems of the conventional therapy, I want to just summarize again what we learned. So one issue that we only briefly touched, but I want to spell out here, is that one of the most effective ways in conventional therapy to decrease the urinary calcium is decreasing the serum calcium. Now, that sounds a little idiotic. If the blood calcium is already low, why would I make it lower? Well, first of all, even a slight reduction in serum calcium can lead to a significant reduction in urinary calcium. So in other words, if your serum calcium is always 8.9, and you are able to lower it to 8.5 and don't have symptoms or you don't feel different from 8.9, well, you actually will lower your urinary calcium. And so that is because the kidneys will excrete what they see. So if they see a high blood calcium level, they will actually lose more calcium in the urine. Right? So that's a very important issue. And obviously, we all know this is limited because of what I said at the beginning, with this balance between blood and urinary calcium and symptoms. Distributing calcium even more evenly throughout the day, 3 times with meals is better than once or twice daily. Some people even need 4 times a day calcium. Add a thiazide diuretic, so that's the hydrochlorothiazide or chlorothalidone. So what is that? That's kind of a pill that's given, it's a mild diuretic, and it's given in patients with high blood pressure to normalize it. But it has this side effect of decreasing urinary calcium. And where does this calcium go? Well, it goes into the circulation and can actually even increase the serum calcium a little bit. So that's actually a really nice thing. It turns out that it only works if your diet is low on salt. So that's a big bummer for everybody who likes salt. And we in the Western world eat too much salt. And then what can I say? It's kind of not always successful. Why not? Well, there are side effects. Low potassium is a typical side effect. Then you have to take potassium pills. And so it's difficult if you're already taking millions of pills and then somebody gives you even more. The other thing is that magnesium can go down. In a very few patients, the sodium goes down. If that's the case, I just say don't take thiazides at all. There's nothing you can do. It's just your body doesn't like those. But some people can tolerate them well and have success, actually. So I personally would always recommend, and with a few exceptions, to try one of these so-called thiazides that's to be given as a once-a-day pill. All right, and then obviously PTH and PTH-like drugs. Well, that's what PTH does, right? It lowers the urinary calcium. That's perfect, right? But then that's not conventional therapy anymore, and that's then not the topic of my talk today. All right. Good. So let's move on and let's briefly talk about calcium supplements. And this is only one slide, but I could talk an hour about it. And I'm sure there are many, many questions about this. So I'm happy to try to answer any questions, and we'll just keep it very simple. So calcium tablets come in different forms and different milligrams, different sizes. Some are pills, some are chewable, some are gummy bears, some are liquids. They come with different salts. So you cannot just eat elemental calcium. It always is a salt. So the typical ones are calcium carbonate and calcium citrate, but there are many, many others. Usual recommended daily dose of calcium for the population is about 1,000 to 1,200 milligrams of elemental calcium per day. And that comes from diet, or most people don't really have dairy or enough dairy or other sources, dietary sources of calcium, as pills. And for hypopara patients, typically, unless the diet has a lot of calcium, often people have to take something like 500 milligrams 3 times a day, right? So it's a little higher than what's recommended for the population, but we are talking about hypopara patients. Now, there are lots of little difficulties and challenges in knowing how much calcium you're actually taking when you're taking your pills. And so you have to be very careful to read the label on the bottle. And then sometimes you cannot buy the same bottle. You have a different one. So you have to really carefully read it again. And that is, for instance, Caltrate is a company's name. Caltrate 600 contains 600 milligrams of elemental calcium. Well, that's easy, right? But then what about Tums Ultra 1000? So you remember that Tums are calcium carbonate also. But if you think this tablet contains 1,000 milligrams of elemental calcium, you're wrong. And believe me, many physicians don't know that. Because Tums really is promoting their tablets as an antacid, right, against acid reflux. And so this is mainly due to the carbonate part. And so they are interested in the carbonate part and the whole thing. So they talk about how many milligrams a tablet has calcium plus carbonate, and that's 1,000, but only 40% is elemental calcium. So it's really 400 only. And I know this is very confusing. And boy, it's the advantage of our virtual visits in this Zoom age with patients instead of coming to the office is that they are at home and they can show me their bottles for the first time. And so they kind of wiggle it in front of the camera, and then I can actually see what I always wanted to know, how much elemental calcium is in there, right? And the other thing is they say, well, for other companies, calcium 1,000 per serving. Well, what's the serving size, right? And so if the serving size is 2 or 3, well, you know it's in 2 or 3 of these tablets. And so we've had a lot of revelations during the COVID times, because now for the first time, I know what people are taking, and so we can discuss that, right? So many of you know these difficulties, but I really can't overstate the importance of knowing how much elemental calcium you're taking. And I personally only communicate about elemental calcium. I don't care about the salt amount. And then in general, calcium should be taken with meals. There are many reasons. So for calcium carbonate, which needs acid to be absorbed, meals provide a lot of acid for absorption. Plus, when you take it with meals, it binds phosphate, so that's really nice. Calcium citrate is particularly useful in patients who don't have enough stomach acid. So either there was an operation, or they have something with their stomach, or people who take antacids. Don't have enough acid, obviously, that's the goal. But so when somebody without stomach acid takes calcium carbonate outside of taking it with meals, then there's not enough acid and it probably doesn't absorb it, right? So they can either take calcium citrate or take calcium carbonate with meals, but typically actually I switch to calcium citrate. Then there are some studies that suggest that calcium citrate is less constipating than calcium carbonate. If that's a big issue, then you can try calcium citrate. But often it's actually not really an issue with constipation. All right, so we still have some time left, I think. So let's talk about the second drug that we use, and that's the active vitamin D. And so that's also sometimes confusing, and what we call vitamin D and what is active vitamin D. So let me just review this briefly with you. So where does our vitamin D come from? Well, it comes from the diet. It comes from tablets that we're taking over the counter. And it comes from UV light when the skin is exposed to UV light. What the body does with these pre-vitamins is to convert them into what is called 25-hydroxyvitamin D. It's just a chemical reaction that makes it hydroxylated at position 25. And that's what is the storage form of vitamin D in your body. It's relatively stable. And that's what we measure when we measure a vitamin D level. So if your doctor say, oh, let's check your vitamin D level, that's what they're talking about. And if they say your vitamin D level is too low, that means, well, the 25-hydroxyvitamin D level is too low. So you either have to take more through the diet, for instance, fish has a lot, or you take more tablets, that's the typical thing. UV light has the problem that it might cause skin cancer, so you cannot go overboard with it. And then, and so these vitamin D tablets are these over-the-counter vitamin D tablets, right? 1,000 units, 5,000 units, 10,000 units, and whatever. There are some strong ones that are prescription, like 50,000. But so if your neighbor says, oh, I'm also taking vitamin D, well, they typically talk about these vitamin D tablets. And then if you have PTH, this 25-hydroxyvitamin D is turned into very active component in the body by the direction of PTH, and that's also done in the kidneys, actually. And that is called 1,25-hydroxyvitamin D, because it's now hydroxylated in the 1 position also. And that's what is in calcitriol. And that's a very potent drug or substance that increases the gut absorption of calcium, and is a prescription drug. And so sometimes, in the past at least, there were insurance companies that says, oh, we are not covering this because it's a vitamin, and we are not covering vitamins. Well, guess what? This is not something you can just buy over the counter. This is a prescription drug, right? It is very potent. It's 0.25 micrograms, right? Remember, like calcium is milligrams, levothyroxine is milligrams, right? And so this is really, actually I take it back with levothyroxine, but calcium, for instance, right? So this is micrograms, it's 1,000 times less. And so we talked about this, and this is given once or twice daily. And this is what you don't want to change yourself, the calcitriol, right? So while you're used to taking extra calcium, and the calcium is when you have symptoms, you really need to discuss any dose changes with your physician. And because it's pretty potent, you also don't want to miss taking it, right? So if you ever miss something, then rather miss the calcium, but not the calcitriol. It's also called Rocultrol, that's the brand name. In some countries, especially in Europe, they use a different kind, it's alpha calcidol, that also has different dosing. So 0.25 of calcitriol is 0.5 of alpha calcidol. All right, I hope I told you useful things about vitamin D here. And that's this calcitriol, right, that we talked at the beginning. So that together with calcium increases enormously the percentage of calcium that's being absorbed through the gut. And if you take too much of it, obviously similar to calcium, you can actually become hypercalcemic. Your blood calcium might be too high. All right, and so now let's talk about the quote-unquote ratio between calcium and calcitriol. Remember, our first case, she was on the 3.78 milligrams, grams, so 3,780 milligrams of calcium, and only 0.25 of calcitriol. So this is a ratio that's way too much in favor of the calcium. And historically, in the United States, a lot of oral calcium was given to patients with hypoparathyroidism. And I was at a conference in Europe virtually 2 weeks ago, and people there said, "Oh yeah, you in the States, you give too much calcium," right? I'm not sure if this is still true, but this was for the longest time, and I have still some patients who come with enormous amount of calcium. So I personally try, not always successful, sometimes you can't help, but not to exceed 1,500 milligrams of elemental calcium per day, combined from diet and supplements. If the dietary calcium is low, or really not much dietary calcium, then I'll just give 500 TID or 600 TID even. And if there is somebody whose dietary calcium, which mostly comes from dairy, is good, then you should not exceed too much dairy neither. Right? Some people say, "Oh, you know what? I have a hypopara. I'm drinking 4 glasses of milk every day and eat yogurt and cheese and stuff," because that contains a lot of phosphate also, the milk products, right? And you don't want to go overboard with. So there's a Goldilocks principle here. But then, if you don't want to give too much calcium, well, how can you get your blood calcium high enough to avoid symptoms? Well, that's then where the calcitriol comes in, right? And so you want to rather limit your amount of calcium tablets. I put in some numbers. Obviously, these are just suggestions, right? You and your doctor will obviously decide what's best for you, but rather than give some more calcitriol than calcium. Calcitriol actually has an effect that lasts much longer than 24 hours, especially in higher doses. And so there's less of this wavy calcium curve that you get with oral calcium. All right. Well, so one weak link in our nice management here is, of course, the inability to check calcium at home, right? It's terrible. That's called point of care calcium check, right? So you can do it at home. And this is kind of the normal thing with glucose finger sticks for people with diabetes, right? And so everybody's very interested in having such a thing at home, but that's not yet possible. Here is an example. This is actually from veterinarian medicine, where they use this in cows, I believe. Looks good, but it has a huge disadvantage. It needs a ton of blood, right? And so this is something where people are working on, and I'm in contact with a group in Virginia, actually, that tries to develop something like this. So, and I know other companies are interested in it. And as an organization, it's actually nice to tell people about the interest. Yes, we would actually love to have a calcium check that we can do at home. What about phosphate? Well, elevated phosphate, again, it's asymptomatic. There you cannot really feel anything. Calcium you feel, phosphate you don't feel. But it is not good to be too high, because it can contribute to extraskeletal calcifications, or calcifications elsewhere outside of the bones. Well, this is due because this is happening because the phosphaturic effect of PTH is missing. And that's why we give calcium with meals. And avoid phosphate-rich diet, all the good things, nuts, chocolate, Coca-Cola, or other Cokes. And PTH does that, of course, does a good job in lowering phosphate. So the guidelines that have just been published, they tell you that for stable patients, we want to monitor calcium, phosphate, magnesium, creatinine every 3 to 12 months, 24-hour urine every 6 to 24 months, depending on the value, right? If it's always nice and low, then you might get to 24 hours. If you have problems with it, you might have to measure it more often. And then following changes in therapy, you probably want to check serum values within days following changes. Renal imaging, that's a little unclear, but the panel there proposes to do this at baseline. And of course, for unstable patients, this is all different. Yeah, you want to measure it much more frequently as clinically indicated. These guidelines, by the way, they have a lot of, it's a treasure trove of stuff. And so I'll just mention you, and I apologize, it's a little small and you might not see it on your screen, but genetic testing is recommended in non-surgical patients who have a family history of non-surgical hypopara, who have syndromic features, meaning features that rare genetic diseases that go along with hypoparathyroidism have in addition, and who are youngish. So here we say younger than 40 years. That's the panel says that. Secondly, we want to avoid the term autoimmune hypoparathyroidism, except in patients who have this rare genetic disorder that comes with different names like APS1 or APSAT, because we don't really have a definite diagnostic test for other autoimmune hypoparathyroidism. There isn't, like for thyroid, there's a test. Here we don't really have a blood test that is a definite test. And then we pulled together the complications from hypoparathyroidism from observation studies, and you see them mentioned here with the percentages. And so you're probably familiar with some of these. All right, so I want to summarize. We want to optimize conventional therapy, and the difficulty here is to strike the right balance between symptomatic hypocalcemia, to have the calcium too low, and long-term complications from calcium that is too high for the therapy that we have with conventional therapy. For most patients, I would avoid large doses of oral calcium, but increase calcitriol instead. Calcium carbonate is actually okay for many patients, and we talked about some of the exceptions. We should give calcium supplements at least 3 times a day with meals. And if the urinary calcium is high, we talked about some of these possible management strategies, including trying a thiazide diuretic with a low salt diet. But as we all know, and I want to repeat this, that conventional therapy has significant shortcomings. All right, so that's this for now, and I would like to open this for discussions and questions if there are any.
Well, thanks, Dr. Mannstadt. It looks like we got about 24 questions in about 10 minutes to try and get through as many as we can.
Excellent. Okay, go.
Yeah. So we'll kind of start at the top. This one's a little weird. It's not weird, but it's talking about pain relief. It says, is it okay to take some type of pain relief medicine, Cymbalta for pain, with conventional therapy? Does it lower calcium levels? And are there any suggestions for pain relief with hypoparathyroidism?
Well, that's a complicated question. So first of all, if the pain is due to low calcium, well, obviously you want to increase the calcium, and that is a little limited. I'm not aware of a direct interaction of pain medications with calcium levels, but pain medications have their own problems, right? So one is if you take NSAIDs, non-steroidals, they can be bad for the kidneys. So you don't want to take high doses, and you certainly don't want to take them more than a few days, right? The best would be to discuss the pain management with your primary care physician and or a pain specialist to see what combinations are best for you. Next question.
Okay. I've seen this question in a couple other panels, so we're going to ask it real quick, and maybe you could give some insight. It says, I wonder that weakness of legs is also a common symptom of hypopara, because it's very hard to give strength in my legs.
Yeah, so if the calcium is low and you have muscle weakness, guess what? It's likely from the hypoparathyroidism. If your calcium levels are actually okay, then it's less likely to be related to hypoparathyroidism. And this sounds easy. It's very hard actually to get to. But if you do have intermittent weakness in the legs, then try to check your calcium that moment, right? And make a little mental note or write a note, timing, etc. And so that, and then also check your calcium when you don't have weakness in the legs, and then compare them, and maybe you find a pattern, right? That's kind of what I would say.
Okay. So for those with insufficient PTH, but they do have PTH, who are then placed on calcitriol, it suppresses their PTH level. So isn't it harmful, leading to less bone turnover, less calcium reabsorption, less gut absorption, and more urine calcium? We see this one come up quite a bit on Facebook as well, this conversation.
Excellent question. I like that a lot. I will give you a more general answer because it really depends on the actual numbers, depends on the numbers of the PTH and what was the calcium at that time, right? So there are many people with hypoparathyroidism who have a detectable PTH, which can be like 10, 11, 12. We are not quite sure what this means. Does it mean there's actually real PTH around and has an effect? Or is it just some remnant or some accuracy of the test? We don't know. If somebody has levels in 20s, I kind of think, well, there's some PTH produced, but it's just not enough, right? Now, does that, and you're right, when you increase the calcium, either by oral calcium or calcitriol, it doesn't have to be calcitriol, you will, this PTH will go down and obviously often go down to undetectable. Is that harmful? I personally don't think so, because from the get-go, it was way too little. That's why you're on calcium and calcitriol, right? And so if it's way too little, it will be way too little for the bones too. So if you take away this way too little, you will have very little effects, actually.
Okay, well, thank you for that. What do you think of extended release calcium tablets, which contain citrate or carbonate versus those just using carbonate alone? Many have found that extended release allows us to reduce our daily calcium intake.
An excellent question, and I have to admit I'm not very up to date with the studies about this. So my knowledge is from a few years ago when I looked at this. There was, I think, a phase 1 trial, but I did not see results of a phase 2 or 3 clinical trial, meaning a rigorous clinical trial that compares one drug versus placebo or one drug versus another drug. So here, for instance, long-acting versus non-long-acting PTH, same amount of calcium in the same groups, right? And I have not seen these studies, so I cannot really comment on how good they are. In theory, I like the idea of a long-acting PTA, long-acting calcium. That would be great, but I have not seen any convincing studies. But I will certainly look tonight whether there are new studies. And surely, if you like it and you think it helps, well, boy, that's the best that can happen. Actually, I hope it's not too expensive though.
Okay, this one is on testing. It says, is ionized calcium always a more accurate indicator of calcium levels in serum calcium? If yes, should it not be the standard test for people with hypopara?
Yeah, this is an excellent question. And just to go back to the basis. So really what the body cares is about the ionized calcium. It doesn't care about the total calcium. What is total calcium versus ionized calcium? Well, calcium in the blood that we measure as total calcium, like 8.5, that consists of a small amount of ionized calcium and an amount of calcium that's bound, not available immediately by proteins. That's why actually we have this albumin, which is one of the proteins. We try to measure that to adjust the calcium for the amount of albumin, because we know this binds the calcium. So in other words, ionized calcium theoretically is better than total calcium, and theoretically it should be kind of the standard to measure. But there's always a but. It depends on the lab that measures it and on what we call pre-analytical factors, meaning from the blood draw in the arm to the lab, what happens in this time matters a lot for the accuracy of the measurement. So it has to be in a tube that is sealed and not exposed to air. It has to be cooled and has to be transported right away. So for most, and there are different methods of measuring ionized calcium, but it cannot just sit around for a few hours and then a runner comes and gets it to the lab, then it's kind of too late for most of the measurements. And because of this inaccuracy that comes from these difficulties in the measurement, we often don't prefer that, but prefer the total calcium because we know that this is accurate, right? There are some exceptions, and if you have or live close to a lab that measures this accurately, and then you can discuss with your physician, should you measure the ionized calcium. By the way, I'm always, I'm very used to the total calcium or albumin ingested calcium and know exactly the small difference, 8.3 versus 8.5 versus 8.7. With the ionized calcium, I don't have the feeling for it because we don't measure it as often. That's also a disadvantage, actually, the ionized calcium.
Well, we'll go, I think we got time for one more. This lady, she goes, hi, I jumped on late, so maybe I missed it. Any recommendations on magnesium? Does it help to divide the doses or specific formula that absorbs better? My son is actually on PTH now, but magnesium levels remain the same. Just wondering if any recommendations help. Thanks.
Yeah, that's an excellent question. So first of all, the guidelines recommend to get the magnesium levels to normal levels by taking extra magnesium. Okay, so that's kind of a recommendation. It's, in my view, particularly important for patients on PTH because PTH works best if the magnesium levels are normal. Those who are not on PTH might want to replete their magnesium if it's really low because it can also give symptoms.
Okay, well, thank you so much for your time. It's always a pleasure to have you with us. That'll conclude this session. Our next session will start promptly at 2:45 Eastern Daylight Time, and that'll be with Dr. Kohlmeyer with Michelle moderating. Thank you again, Dr. Mannstadt.
Well, thank you, and thanks the audience very much. I enjoyed it. Take care.